our first presentation uploaded on our CME platform, done by one of our national heroes. Now, Dr. Bizri is a national hero, really. I'm happy to introduce Dr. Bizri, who is the president of the National Committee for COVID-19 Vaccination. Besides being a well-known and a well-reputed clinician and infectious disease specialist, he is doing really a great work. And I think that most of healthcare professionals, and especially doctors, are really waiting for Dr. Bizri for what he is going to say to us tonight, what he's going to teach us about these new vaccines. And we will take the opportunity to thank him for all the effort he is doing. And I think we all owe him a big thank you for the effort he is doing to get this healthcare corpus immunized and protected against COVID-19. Dr. Bizri, the floor is yours.
Thank you. If I may share the screen, is it okay? Can I share the screen? Share screen, yes, okay. All right. Thank you, Dr. Zoughbi, and I think good evening, everybody, and I think you are part of an important and integral part of what we are doing. And I'm trying today to go directly to what everybody wants to know and quickly and discuss some of the few developments that took place, whether internationally or at the local level. So the COVID-19 various vaccine platforms and what's available for Lebanon now is very important. We know that the Ministry of Health has achieved through direct negotiations a deal with Pfizer to provide a messenger RNA vaccine and to provide around 2.1 million doses of that vaccine. This is very important because this vaccine has really been proven to be quite a potent vaccine and leaves a very good efficacy. The second important news is that they have also managed to achieve a very good deal with AstraZeneca for 1.5 million vaccines. And there is on the table an offer from Johnson & Johnson, which is another vaccine that can be given once daily, one dose instead of 2 doses. However, the problem with the Johnson & Johnson that it will not be available for Lebanon except in the month of September. However, Lebanon is already one of the countries at the top of the priority list for the COVAX platform, where AstraZeneca is going to be supplied as well from the COVAX. And a good news is that we are going to receive AstraZeneca as early as the end of this month or probably the first week of March. So this means that we can have a lot of flexibility in our plan for vaccination and in our national initiative. Pfizer is also another option for us at COVAX, so we are still hesitant for that. We are considering, although Pfizer is an important vaccine, yet it's a very difficult vaccine to handle. Novavax, which is an interesting vaccine, and is also another option for us when the time allows, as well as Johnson & Johnson. We are also receiving some potential donations. As a country, we are going to receive from India a donation for the AstraZeneca vaccine, yet we are entertaining several donations. And I think the word donation does not fit the profile here because now we are going into what we call a solidarity platform, which means that the Lebanese society is a resourceful society. We are going into a solidarity platform where we are going to get a lot of sectors in the community to put together their efforts and their resources, assets, and finances in order to purchase vaccines for the Lebanese community, albeit for certain sectors together, but everything when put together under the umbrella of the national initiative will reach its target. Our target is to achieve 85% social and herd immunity in Lebanon, and this is very important for us. So this probably sector is going now to gain momentum gradually. We have offers from politicians, we have offers from sectors, and they are willing to be under the umbrella of the initiative. The private sector can be also an important component now. Sinopharm has applied, although the file is completely inadequate, and they do not provide any data except phase 1-2 data that is present since several months in the Lancet, but there are no phase 3 data. Yet it seems that they have managed through a certain way to penetrate one of our most important establishment as a potential donation. So we are monitoring this. Sputnik is a very interesting player, especially with the data that was published today. And we have received the same file, like the data that was published today, to look at it. And we are going to give our verdict by Thursday or at best Friday. And I think it's going to be a very positive verdict. Another player is going to be Bharat. It's an Indian producer of vaccines. This is a live attenuated, this is an inactivated vaccine. Sputnik is an adenoviral vector vaccine, and Sinopharm is a subunit vaccine. So all of these are all present on the table now. As we said probably before, that the aim of the national COVID vaccination initiative is to achieve the first 3 levels: to prevent infection, to have an asymptomatic infection, and definitely if disease was formed, it should be really a mild to moderate disease that does not really necessitate hospitalization, intensive care, or later on an happy ending. So if we can achieve at least the phase 2, we can achieve prevention of transmission. And data from occupied Palestine today through the Israeli occupation authorities have today showed that since the Israelis were quite progressive in vaccinating their people, they are really witnessing a severe decline, a sharp decline in the incidence of new COVID cases, which really, this is one of the good first evidence that vaccination can decrease the incidence of the disease and the circulation of the virus. More important, in the United States of America has opened the schools based on their now improved vaccination level. And the United Kingdom, which was a bad example for an advanced country that really was not performing very well, when they really moved towards immunization strategy different than the initial one adopted. Now they are really having much better figures as published soon. And this tells us that all of these are indirect evidence that vaccination works. So to us, really, what we really care about are the following, the first 3 scenarios. Prevention of an infection, where the burden of disease is going to be equal to 0. Asymptomatic infection, a burden of disease also equals 0. Mild infection not necessitating hospitalization. This is also desired, where the burden of disease is also 0 or minimal. Moderate infection, this is less desired, where burden of disease is estimated as 1. Severe infection, hospital plus possibly ICU is not desired, burden of disease equal to, and mortality definitely not desired at all, burden of disease equals 3. So vaccine efficacy is already proven, but vaccine efficiency is what we are looking for. Efficiency is what we detect when we use the vaccine in the community, and we are aiming to try to achieve the first 3, and to convince the public that vaccines are helpful, and to convince the politicians and decision maker that it is a very well investment, and that the economic investment as well as the health investment was worth it. So these are the vaccines that we already have or are going to have. The Pfizer vaccine will start vaccinating people as early as February 17. We are going to have the first 28,000 doses by February 17, and each week we're going to get somewhere around 30,000 doses. So by the end of March, we're going to have 250,000 doses of the Pfizer vaccine. Hopefully, in the second phase, the second quarter of the illness, the numbers are going to get much more larger and bigger. So this is why we need to keep the major centers, and whether be it governmental or university centers or hospitals that are capable of handling this vaccine stand by, because these vaccines need special handling, and we have really put a very detailed plan of how to manage this vaccine and how to adequately provide it. So most of our healthcare professionals are going to get this vaccine, because this is the first vaccine available for us, and the first line of people who are going to be vaccinated are going to be the healthcare professionals. And we are going to get the data from the Lebanese Order of Physicians and from hospitals, and we want to integrate this data into our platform. At this stage, we have around 200,000 plus people who individually have registered on the platform. We expect the figures to get much larger soon. And when we add the figures from healthcare workers, we're going to get a decent number. The viral vectors, AstraZeneca Oxford vaccine, is going to be soon available in Lebanon, as I said, and this vaccine will give us, as a program, as an initiative, will give us flexibility. We can go to areas that we cannot go with Pfizer, and we can reach certain high-risk population that we cannot reach with Pfizer, including, for example, those incarcerated and detained people, and those staying at special need and special care facilities, home care for the elderly, special needs, and so on. We can go and reach them there and vaccinate them. Jamalia Sputnik 5 is an important player now, and it's soon going to be into the country. Today we met and discussed the file, and the file is supported by the publication that I will show you some of the information that was published today in the Lancet. The Russians are very much interested in having their vaccines in Lebanon. It is a medical and a political issue for them, and it seems that, as we mentioned, as we heard from the ambassador, it's the President Putin is interested in this issue as well. So this will also give us flexibility, given the very nice results we had in the Lancet that will encourage us to use this vaccine. We have two subunits vaccine that I'm still very hesitant to use. The Sinopharm Chinese vaccine, which many Lebanese have acquired it vis-a-vis either traveling outside or vis-a-vis a political kickback or whatever. We don't know what to do with this group of patients who received it so far. And it seems that it has been probably put at some pharmacist. I'm not clear about it, whether this is true or not. Bharat is another Indian vaccine that today provided their data. It's an interesting vaccine. We know India is an important vaccinology country, but I'm not very well aware of Bharat. I'm more aware of the Serum Institute of India, which will be our main provider of AstraZeneca, as well as the Russian firm that produces AstraZeneca. The other vaccines are still on the table, so I should have removed this from here. And we are interested in the recombinant spike protein Novavax. The data here is very encouraging, and I will show you some of these data. And especially that the file was provided to the FDA, and soon we'll get some approvals. It is part of the COVAX package that we can get it. The Sinovac vaccine, we refuse it utterly and completely, since data from Brazil showed at best 50% protection, so it's not anymore on the table. So this is the data. I will show you the data to compare very interesting data together. This is the data from Pfizer-BioNTech, which showed 95% efficacy and only one severe case after one single dose. So it almost has 100% efficacy with 2 doses against severe cases, and it has somewhere around 90% plus efficacy against all other cases, including mild to moderate disease. The interesting data is this graph, where you can see at day 12, those vaccinated are quite significantly separated from those unvaccinated. So this is why a single dose vaccine may provide an adequate immunity at least. And this is why many authorities in the world are moving now towards delaying the second vaccine dose. In Lebanon, we are not considering this. It is still a thought in our mind to entertain, but we're not considering it. I know in the UK they are doing it. I know that the French NITAG strongly has a statement supporting this, that instead of giving the two vaccines in a 3 weeks duration, why don't we extend them to 42 weeks, so we can vaccinate more people and prevent the transmission of the disease. I know that the CDC is becoming more lenient with that, but we still need some more confirmation. It's in our mind, but we have to go. We'll go back to the committee and definitely to you to discuss that in the future. But for the time being, we are sticking to the classical protocol, pending more information, and this could be an item for discussion later. The side effect of this medicine, which many people, unfortunately, with false identification and false claim are attacking, and seems to be an acceptable profile. And it seems that the systemic and the local events are acceptable. However, it seems that the more you the more you develop side effects of this medicine. Yani you're getting what you call a little bit fever, a little bit sick after getting it for 1 or 2 days. You're feeling unwell, really correlates very well with your antibody response. So this is a sign that you have really responded much better. So one question also for discussion later with you is that some people say, since it leaves a little bit of people feeling unwell for 1 or 2 days, why should we really try to cover all the healthcare sector with this vaccine? Why don't we try to separate the healthcare sector gradually, so we don't have what you call 200 healthcare workers feeling unwell for 1 or 2 days? So this is also an item for discussion, but this is also a fantastic vaccine. This is the Sinopharm vaccine. The Sinopharm vaccine was tried in 2 doses. They stick to the lower dose because of lesser side effects and more tolerability. Unfortunately, no data exists outside the phase 1 and 2A. In this phase, it looks to have some certain good response. We asked for details from the company, and from the embassy. They are refusing to provide details, but I know that they have a package and they have a deal, which I don't know how it was made, with the Lebanese army, and the Lebanese army wants us to endorse this vaccine, despite the fact that there is no strong data about it so far. This is data from Johnson & Johnson. This is very interesting data. It was published yesterday only, and it shows that it has 100% protectivity against severe disease after the second dose, and 85 after 28 days. Sorry, it's a single dose. After 49 days, 100%. After 28 days, around 85%. So this is really a very protective disease. And it has an overall protection of 72%. But mind you, when this data was done in United States, it included some of the variants that are circulating. So the data, so you cannot compare data Johnson & Johnson with data of Moderna or Pfizer, because the population in the United States has changed a little bit because of the circulating variants. This is a very interesting vaccine, the Novavax vaccine. It is a whole recombinant spike protein. It's the whole spike protein, not only the receptor binding domain, and it also has what we call a matrix M1 adjuvant to induce CD4 T cell response. And the side effects seems to be very well tolerated. There were no side effects, as you can see, very minimal severe adverse events. But if you look at the protective data, you will find that this is very interesting as if we compare it to convalescent sera, especially in those who were really hospitalized with severe disease. You would find that the antibody response is very well matching and even superior to that. And if you look also at the neutralizing antibody, not also the spike antibody, you will find also that the response is really equivalent or superior to severe human convalescent serum. The interesting data was published yesterday. Was public, and this is very interesting. They said that it is around 90% efficacious in the UK phase 3 trial, where at least more than 50% of the cases were attributed to the UK variant. So this is the first time we have a good study that includes the UK variant. We know that the variant in the UK has been tested also against Pfizer and Moderna, and they showed efficacy. But this is the first time that we have such a large number where people are more than 50% of the group have UK variants, and they are really protective. There was no severe cases, and severe serious and medically attended adverse event occurred at low levels and were balanced between vaccine and placebo. More importantly, there is another 2B trial for this vaccine in South Africa. And we know that South Africa has another variant, which is also quite resistant. And the number of cases here, the number of participants in the UK was 15,000. The number of participants here was 4,400. And it showed really 60% efficacy for prevention of mild and moderate and severe COVID disease. In up to 94% of the population studied, and there was no severe cases at all in the vaccinated people, whether they were HIV or not HIV, and this is really an important vaccine to entertain, especially that we can have this vaccine in the future. The AstraZeneca vaccine, which is coming to us soon, you all know about it. You know that the efficacy range is somewhere between 70 and 90%. And you know that one problem with some European countries is that the data in the elderly people was not really very large. So this was an argument between some local authorities in Europe and the European Medicine Agency. However, the European Medicine Agency said that given the fact that the immune response was so potent, they believe that it's going to be adequate also for the elderly population. And these are some of the profiles produced by the ChAdOx vaccine. This is probably one of the easiest vaccines to handle because, for example, the Johnson & Johnson vaccine, although you can put it in the refrigerator, yet you have to ship it as frozen at -20. But when you receive it, you can use it in the refrigerator, and it has a 2 months life span. You can use it adequately. The AstraZeneca vaccine, you can ship it in regular cold chain, and you can keep it for 6 months in the regular cold chain. So this will give our program a lot of flexibility. And given that the variants circulating in the UK are still circulating there, and given the fact that now immunization have shown a significant drop in the incidence of new cases, so we have to assume that vaccinating people in general is going to be helpful to prevent further propagation of the variant strain, because we know that strains usually propagate when the virus is allowed to circulate freely. The most interesting data today is the Russian data, and I will be very explicit about it because this is we are going to judge it. This is the data we received, and this is the data that was published in the New England Journal of Medicine. We received a larger file definitely than that. And you can see the safety and efficacy of the Russian vaccine. And you can see 21 days after dose one. Yani, this is the time where you're going to give the second dose. So before giving the second dose, and you can see there is an overall efficacy of somewhere around good efficacy range, good efficacy range. And you can see these are the numbers. And if you look at the efficacy occurrence after the first dose, after you give the first dose, you will find that the efficacy is also very potent. And the overall efficacy has summed after giving the second dose, يعني 28 days after the first dose, and also around 1 week after the second dose is around 91%. So we have really an easy vaccine to handle. 9%. We have to look at the shipping techniques, because depends upon how you are shipping this vaccine, whether it needs a -18 or a regular fridging. We are asking about these details now in specific. And we know that we have two offers. We either get it directly as a vaccine, or they will give it to a Lebanese producer in bottles, and the bottles will be wrapped up in Lebanon, يعني, the cartoon boxes outside, and will be produced at the local market. But this is the same molecule itself. And if you remember the Pfizer data, you look, this is very similar data, where you can really see the very nice response almost at probably 14 or 18 or 17, 18 days, where really you can separate, before even giving the second dose, you can really separate between the placebo and the vaccine. And you can see how significant the drop has occurred following this vaccine. And if you look at the receptor binding domain specific antibodies in all age group, you will find that they are comparable. They are really they are really very high, and they are really comparable. So this vaccine is probably active at all age groups indicated for vaccination. And this is also the safety, and this is also the neutralizing antibody profile. And you can see that there is no gender difference, and there will be also significant response at all ages, although here the confidence interval is very wide, which a little bit is not very helpful, but in general it seems to be acceptable. So this is another addition to our armamentarium that we may be really dealing with. So the few questions that has to be answered, interestingly enough, this article is not published yet, but because everybody is asking whether you are going to immunize the those who have really acquired the disease or not. In our policy, as Dr. Zoughbi knows, that we said that we'll probably wait for 6 months to immunize them. Most of the recommendation were for 3 months, but we said because we were really getting initially very low quantities of the vaccine, so we can probably change our what you call strategy once we get more vaccines coming to us. But this is very interesting here. This data has been sent for review. 109 vaccine recipients in the United States and France, 38% of whom were seropositive, had SARS-CoV at the time of the vaccination. Median antibody titers among sero vaccine who really were vaccinated even after receiving the first dose, but were much higher, 10 times much higher than those who did not really get COVID and who get 2 doses. So the question really that's raised in this paper, you are going to get more side effects if you had COVID before, but you're going to have what you call much more good immune response and impressive immune response. So the hypothesis here that's going to be asked, and it needs to be answered later. We don't have to answer it now. We probably have to answer it later. Is that do we really should we be satisfied later with one single dose for those who have had the vaccine, or we go for the 2 doses? I think time will tell, but these are very interesting issues to be answered. This is what I'm talking about. Those are who had really seropositive, and you can see that their response really was much more impressive, even at the first dose here, even much higher than the second dose in those who were not really seropositive before. So this is a good clue for us to follow. So this is another indication why we should really vaccinate those people, because it will be another extra booster dose. So I will stop. I will try to finalize by summarizing all the vaccine available in Lebanon and their suitability for our market. The the AstraZeneca is really suitable for Lebanon price-wise and practicality-wise. Moderna remains to be a theoretical option, but I'm not aware that anybody really is interested now in bringing Moderna. I know that one of the politicians contacted me and said that he may be able to get Moderna, but I still doubt that this is a possibility at this stage. Pfizer is definitely with us coming here. It's the only vaccine who has the 3 approvals, FDA, EMA, and the WHO. The Sputnik is really quite interesting vaccine to consider, especially that if we decide to adopt it. Johnson and Johnson, we're going to get limited amounts if we want it, but one single shot is equivalent to 2 doses. This may make life easier for us if we still need vaccine by September. The Sinopharm remains to be an enigma, but I know that by one way or another, they managed to penetrate the army, and the army has signed a file, and they wanted us to evaluate after signing the file. So we are looking into this data and trying to advise the army. The Novavax is a very interesting vaccine, and we don't know anything about the price. My impression, it's going to be a little bit expensive. And so an ease of handling here, they definitely, all the adenoviruses can be handled easily, and all the subunit vaccines can be handled easily. The suitability for Lebanon has been evaluated in this tablet, so in this table. So we probably may have some suitable vaccines that can expand our spectrum and speed up our vaccination policy. So the plan we put and we sent to the Blood World Bank, which was accepted with a lot of good comments. We told them that this is what you call a flexible and the dynamic plan, depend upon the type of vaccines we are going to get. And this is what I mean, because we are now start working how to accommodate for the AstraZeneca vaccine, and soon probably how to accommodate for the Chinese vaccine with the army and the Sputnik vaccine in the market. So I will stop at this stage and allow the floor for questions.
Thank you, Dr. Bizri. In fact, we have a lot of questions from the audience, and I would like to ask all the audience if they have additional questions to post them on Facebook. So the first question is easy. How can we get the slideshow?
You can get all my slides. It's easy. So I will tomorrow I will send them to you, Dr. Zoughbi, and you can disseminate.
Okay. So no, and the answer is easy because it will be posted on the CME platform of the LOP, so it's easy. So Dr. Sharbil Rahmi is asking, when the vaccine arrive, will the second dose be reserved already when we get the first one, or might there be delays?
No, we're going to give the first dose immediately because we know that the second dose is coming the second week after, and we have confirmation of 7 weeks to come, and they are already confirmed.
Okay.
So we have
Thank you.
confirmation for 7 weeks coming, yani. So we are planning to give the first dose full, and the second dose full, and the third dose full, the fourth dose full, and then after the fifth dose, we'll look for further confirmation. Let me tell you something. In my capacity as the chair of the committee, I contacted the European Union authorities, and they confirmed that Lebanon is not part of the restriction of importation of vaccine. So Lebanon is exempted from this restriction, and we can get any vaccine, be it European or American or anything produced in European territory. We can get it, and we have the same also reaffirmation from Pfizer itself.
So we have a question from Dr. Danny Ghulam. He's asking about if we are going to administer the AstraZeneca vaccine to patients older than 75 years.
Well, you see, we are interested in administering this. According to the European Medicine Agency, they believe it should work. And although there is little data about it in the numbers, it should work. We are probably, this vaccine will provide us with some flexibility. One suggestion is when we go to the prisons, we can provide the AstraZeneca, because if you want to provide the Pfizer in the prison, first of all, the side effects are a little bit tougher. Second, the way you have to provide it takes much longer time, so it needs a mobilization of a lot of elements. So the AstraZeneca vaccine is easier. Probably when we go to special situation or special institutions, we may really give the AstraZeneca. And as the Naib wells know, and today we were probably attacked indirectly by one of the political parties, because everybody wants to have several centers in their region. So this vaccine will probably extend our reach. This vaccine will probably extend our reach, but we are sticking to what we should do. Our priorities are our priorities, irrespective of the vaccine. And to answer a question probably unasked, we are not allowing the individuals to select which vaccine they want. We are offering a certain vaccine at a certain center, take it or leave it, unless we find a good reason for avoiding a certain vaccine in a certain situation. A good example is that severely immunocompromised individuals, I would spare them the adenovirus vaccine and give them the Pfizer or a subunit vaccine. On the other hand, if somebody with severe allergy, I would prefer to give them the adenovirus vaccine and not necessarily the Pfizer vaccine. So as a committee, we will probably give ourselves some flexibility to tailor certain vaccines to the best of the Lebanese individual, but we're not going to allow them to select.
So another question from Dr. Rafiq Abu Dawood. If the patient got infected between two vaccines, will you give the second dose?
I probably will refrain for at least 3 to 6 months, and this patient may deserve, because there are not going to be many, this patient may deserve an assessment of their antibody titer later, because as we are now assessing and seeing that a mixture between vaccine and infection can really exaggerate the immune response. So this is worth evaluating at the time, but definitely not the second dose on time.
Another question, Dr. Abu Habib is asking if we need to have IgG for adenovirus before getting the vaccines based on adenoviral vectors.
Not really, at least with the AstraZeneca, not really, because we got the human adenoviruses. The AstraZeneca is a chimp adenovirus, so it should really overcome this issue. And since we are not getting any antibody before giving any vaccine, why should we get the adenovirus antibody as well?
So we have a lot of questions about the logistics. So maybe you could give us an overview of the logistics, how vaccination will be done, maybe at the end. Now we will go with the scientific question. what is your impression about the safest vaccine? And what about pregnant women?
I think all vaccines are safe. I think the messenger RNA is a beautifully safe vaccine. This is a molecule that will decay in a very quick period of time, and it will leave a good immune response. As for pregnant women, I think this vaccine is very safe for pregnant women as well as the subunit vaccine. Our recommendation in the committee and the recommendation of the international bodies is to give pregnant women the vaccine, but after consulting with their own obstetrician. So this is what was our recommendation, is that a pregnant woman will not be denied a vaccine, but it should be preferably be after consultation with the obstetrician. The same with the lactating mother as well. And even with the severely immunocompromised individual, we know we can give them safely messenger RNA, but we probably have put that they should consult with their hematologist, oncologist, but just for that sake as well. Okay.
So I have a question. The name is not clear, but the question is, a patient who got acute diplopia following hepatitis B booster dose, which type of vaccine is contraindicated in such a patient? I don't know if you have an answer to this, Dr. Bizri.
I don't have an answer whether the diplopia is related to the vaccine itself or not, but we know that the Pfizer vaccine in general, or messenger RNA vaccine in general, you should really be very careful if you have a very strong anaphylactic reaction for the vaccine, but I don't know this one. Maybe at that case, we should probably individualize and check. I admit I have no answer for that, but it's worth looking at.
Okay. So here, a question about doing the IgG test before using the vaccines.
I think it's a waste of money, waste of time, waste of labor.
So it will not be
recommended.
No,
we're not. It's not recommended, and it will not affect our decision to vaccinate or not certain individuals.
Okay. Doctors are asking if they have the choice about which vaccine to receive.
I answered that. I don't think we're gonna give the choice. No program in the world have given the choice to anybody. However, we will look at, since we have the medical record of the patient on the platform, and we know some of their medical history, we may elect to give, to sway from one vaccine to another in certain individuals. But generally, we are going to provide vaccines as they come.
What are the precautions to take after vaccination? It figures in the plan, but if you want to say...
It's the plan, we have... I'm being bombarded by... the plan is easy. Everybody who is vaccinated will stay for 15 minutes in the vaccine center. There will be a physician at all times there. And if those patients put on the record that they have allergy to vaccines or severe allergy in general or allergy, we're going to ask them to stay for half an hour for observation. We have a small questionnaire that will be asked to people before registering into vaccination when they come to the center, and we're going to monitor them. And there will be on the platform, after getting the first vaccine, a way by which they will tell us whether they experienced any of the side effects, and we'll educate them about that. And we'll soon launch our what you call center for COVID vaccine that will also supplement this activity and help people who are not really very handy with the platform.
So we have a question from President Remo Sayer. He is asking to summarize again, what are you recommending for the infected cured doctors? Those who got the infection and are cured now.
In case of Ramon, he can get the vaccine because he has exceeded the 6 months period. So usually if we have enough vaccines, we're going to give them for 3 months and above. But since we have a limited amount of vaccines, we're going now to those who were vaccinated can get the vaccine after 6 months. However, once we start having more vaccines coming, we can loosen our recommendation and get it between 3 and 6 months. But we recommend definitely vaccination for them.
Okay, another question from Dr. Lilian Saeed. When should the revaccination be done? After 1 year, perhaps, or does it need more time?
Well, we need more time, but we don't know. It's too early, too soon to tell. The idea of the current vaccination is to interrupt the pandemic, and we hope we can interrupt and hold the pandemic and resume some of our normal life that we have lost. To worry about the future immune status is probably premature at this stage.
Now we have a question about patients with G6PD deficiency. Should they receive the vaccine? And other questions about patients with the hematologic disease.
I'm not aware there is a contraindication for that, and the components of the vaccine do not contain any of the material that should be. My best awareness is that the contents of the RNA vaccines that will probably are mainly contraindicated are those who who have what you call allergy to the material that you take when you clean your bowel in preparation for the bowel. I know that Miguel Aboud has opened his camera, so he's interested in answering that since it has an hematological component. Miguel?
We're listening to you, Dr. Aboud.
Abed, thank you for giving me your link. And the short answer is hematologic disease patients in general should receive the vaccine. I can talk about sickle cell disease and thalassemia, others as we go along, but in general, yes.
Okay. Dr. Ghada Hakim is asking about patients with autoimmune disease. Could they get the adenovirus vaccine if they refuse the Pfizer one?
Sorry, question, I didn't hear it. Marouan?
Yes, they are asking about patients with autoimmune disease, if they have to refuse the Pfizer vaccine and if they would prefer the adenoviral vaccine, the AstraZeneca one.
I'm not aware in autoimmune diseases should be handled. I know theoretically they should be handled with care, but practically, if you look at most recommendation of authorities, they are not really discriminating between vaccines. And we know that many neurologic societies and autoimmune and rheumatology societies have probably is really pushing for vaccination rather than restricting a vaccine or selecting a vaccine.
So Dr. Dolly Noon is asking about the immune response in patients who are immunocompromised or who are under receiving chemotherapy. So will they develop the immune response and will get immunity from vaccines?
I don't know. This is very important. I know this is very important because we know that immunocompromised individuals deserve to be vaccinated. Those on cancer treatment, chemotherapy, and other treatments should get vaccinated. Whether you're going to give them the treatment during the acute, you're going to give them the vaccine during the acute treatment phase, or you would delay it. This is probably up to their physician to decide with the vaccination program.
Donc,
we
have a question about multiple sclerosis patients.
Yeah,
any contraindications or special precautions?
In fact, the American Society and the European societies are strongly suggesting to be vaccinated. So they have already a position paper.
So are there any long-term concerns about the long-term safety of mRNA vaccines?
Should not be the case, because we know that mRNA is a very unstable molecule. It doesn't go into the nucleus, it remains in the cytoplasm, and it will decay very quickly. So people who talk about molecular integration and other things, it's probably not true. So it remains to be a safe molecule.
So Dr. Biagini is raising the question about allergy to eggs or fish. Any contraindication to any type of vaccine with these allergies?
I'm not aware because they are not part of the vaccine components. Even now, even influenza vaccines now have removed the egg allergy from the influenza vaccine because they probably are not really culturing them on yolk egg anymore.
So a question about the effect of vaccination on asymptomatic spread of the disease.
Well, we know from the, unfortunately, from the Israelis that the disease is, that vaccination can influence the disease. And we know that in a certain subset of patients, the vaccine can protect against infection. But to be fair to all people, we have to tell them that even if you are vaccinated, you may get an infection. So they have really to keep the social distancing and all the precautions until we reach the 85% social immunity levels we are looking for.
So Mrs. Shahwan is asking about how far should we take the COVID-19 vaccine if we got the flu vaccine? What is the time?
Usually 2 weeks, any separation between any two vaccines. So if you want to take any vaccine before or after the COVID vaccine, now the duration is 2 weeks. We are considering this when we are taking into consideration those people who want to go to pilgrimage and they want to take the meningococcal plus or minus the pneumococcal vaccine as well.
So what about taking the Pfizer vaccine after they got a dose or 2 doses of the Sinopharm one?
Nobody recommends mixing between vaccines. If they have taken two doses of Sinopharm vaccine and they are not happy about their immunity, let them check their immunity. I have checked some patients who are my friends and they went to UAE and took the Sinopharm. The two I checked, they had really an IgG antibody. So what was the level? It was not a quantitative, it was a qualitative level. So I don't know, but if they are suspicious about the level, let them check their level before considering anything else. But they will maybe there will be re-stimulating their immune system again, and they may have an exaggerated response. We don't know that because nobody has really recommended such a practice.
So now we have a lot of questions about the logistics. So we'll start with Dr. Samaha, who wants to know if there will be differences in time between different specialties. So all the doctors will get the vaccine at the same time, or will they, first liners will have the priority?
Well, you see, the first liners are a concept, which means those who are really dealing with the COVID patient or exposed to COVID patient. But with now the spread of the COVID all over, then probably anybody who is seeing a patient is becoming some sort of a first liner. But in order to be fair to everybody, we asked each medical center and we're asking each place where they have COVID patient to try to classify their own first liners. And ultimately, we're going to speed up the coverage for healthcare workers as much speedier as we can in order not to create gaps among them. But like anything else in the world, if you have a limited amount, you have to have some sort of a scientifically preferential positioning.
So can we have some clarifications about how it will be delivered, the centers? Because I have a lot of questions about refrigerators. Where are we going to store the vaccine? How it will be handled? How it will be taken from one place to another? Can we have a brief summary about this?
Yeah, sure. Yeah, sure. The vaccine, I'm talking about the Pfizer vaccine now. The Pfizer vaccine will start the trip from in Belgium. It will go with a UPS carriage that has a GPS and the thermostat. It will go from the factory to the airport. In the airport, it will be shipped to in a Middle East airline where the GPS and the thermostat is monitored. Anytime we lose either GPS or the thermostat, the box will probably be discarded and will not accept it, and Pfizer has to replace it. When it comes to Beirut Airport, the UPS also will handle it. We have two options here. The Ministry of Health preferred the first option although we in the committee were probably for the second option, but we decided to mix both options. In the first few weeks, when we have a small amount, we are going to put all the storage material in the -70 fridges at Rafiq Hariri University Hospital, where they have two large -70 ULT freezers. And then we are going to use the cars of the big pharma. The big pharma in Lebanon, although those who do not have vaccines have really thankfully donated their cars to ship the vaccine for us into the medical centers that we consider as vaccine centers. And they will going to be shipped with what you call a cold chain between 4 to 8. So the cold chain will start its trip, let's say in the morning or in the evening, late in the evening or early morning. It will reach the center where once it's still in the box, it can be kept from between 2 and 8 for 7 days. Once you open the box and you remove the dry ice, it can be kept in the fridge, in the regular fridge, between 2 to 8 for 5 days. So this is where the center should consume the amount sent to the center in 5 days' time in order not to have any waste. As for the trip by the individual will register on the platform or vis-a-vis, let's say, the Lebanese Order of Physician. They will get an appointment. The appointment will be sent by SMS or other notification. There will be a reminder. They will come, they will show their registry, they will show their ID and the number they receive from the platform and the whole full name. They will be asked a few questions, and then they will be allowed into a waiting room with social distancing. Then they will be allowed into the vaccination cubicle. From that, they will be asked to wait in a waiting room with social distancing. There will be also always at any time an emergency carriage with anaphylactic medication and cardiopulmonary medication, and people trained to do ACLS and anaphylaxis management. And then they will be asked later to discharge, and they will receive discharge notice with an appointment to come back that they will be reminded of by the SMS once again.
Thank you. So we'll go to our last two questions. One legal and ethical question: who will cover the doctors when they are going to vaccinate patients if they have any complications? And who will cover doctors who got vaccinated if they have any anaphylactic reactions?
Well, you see, we're not consenting anyone. You have a platform, you have filled it. You know all the details about the vaccine, the advantages and the adverse events. So the mere fact that you have applied to the platform, it means that you are going to, you know what you are dealing with, what you are not coming for. This is one. Two, once you sign on vaccination, means that you have already signed on the vaccination form. I refuse to have any consent form, because a consent form is a form you give for clinical trials, not for vaccines. In case something happened which is outside the box, then the responsibility is that of the Ministry of Public Health. And this is the law that was recently issued by the Lebanese parliament.
Okay, we have an interesting question from Mrs. Jacqueline Shahwan. She's talking about the abuse of the platform when patients are putting some incorrect informations, and then they can get reports from some physicians with false information. So maybe this question has to be addressed by Dr. Bizri and President Sharaf. So what are we going to do with abuses from patients and from doctors?
You see, let me speak quickly, and I will let Professor Sharaf elaborate more. We have put some sort of a phrase that this information is really should be true, and you will be what you call persecuted if you were going to say otherwise. We may allow one or two a physician once or twice to give some sort of a kind leverage to some of their patients. but just to work as what you call trying to issue falsified statements, this is probably unethical of physicians. And I presume that most of our physicians have the decency not to do that.
So I don't know if Professor Sharaf has something to say about this, or a word to say to doctors about this.
Dr. Husari from America.
I don't think so. My last question is, can we have the scoop tonight and announce to doctors when will be the first dose given in Lebanon?
I think it should be 17th of February. So February 17 should be the first dose. So let them get ready. And I think, and I'm sure the first one I'm going to give the vaccine to is Nasreen. So, I think we are already there. We have to wait for a few more days. And I think choosing the doctors and the healthcare workers to start with is important. It protects our healthcare system, and really it protects our people who are in the process of vaccination. And we all in the healthcare system can tolerate each other. Probably the first thing I will do is if a center can afford to vaccinate 400, I will give them 300 initially to see that they get used to it more and to become more familiar with the Pfizer vaccine. So when the non-healthcare workers come, which probably will not be as tolerating for us as we can tolerate each other, we become more efficient and more professional.
Dr. Bizri?
Yes.
Can I make a quick comment? This is Ahmed Husari from Los Angeles. I want to say that I took the 2 shots for Moderna already. And I'm involved with our drive here at the hospital, and we give 1,800 patients a day. And over the last 1 month or so, we had only 2 patients who had to go to the emergency room and given a shot of steroids. So you can see the side effects from real experience is really non-existent. And the patient population are really very old population here, unlike Lebanon, where the majority of us are not that old. So the safety record we gave Moderna and we gave Pfizer, and the safety records for both of them is unbelievably good. Now, you're gonna feel 24 to 48 hours of malaise, weakness, fatigue, and you can take some Tylenol for it, and that's really about it. So this is our experience here, and we're vaccinating almost 1,500 to 1,800 patients a day. So the numbers are, it tells you about the safety of the procedure. It's so good to see Dr. Bizri, or to see Nasreen and everybody, and I wish you guys the best, and I love you guys.
Thank you, Dr. Hassari, for this intervention, because we benefited from your experience and from the American and British experience to monitor the side effect of this medication and how we can manipulate the vaccine later if we need to in case of emergency, because we are living in what you call unprecedented times, and we have to be vigilant and careful and ready for any possible scenario. And this is what we are doing. Thank you. I wish all Lebanese physicians who claim that they are physicians in America will speak the truth, because some people who are really claiming something they don't own or they don't have are really spoiling our campaign. And this really has to be dealt with severely. Today, I refuse to go on 2 TV channels because of that, because of misuse of media by unqualified people.
Absolutely. Take the vaccine. Take the vaccine. And thank you, Dr. Bizri, for all your work.